Start பண்ணுவா sir. Okay sir. Good evening all. So we'll start again with the questions. So the next question we'll see is smoking causes all except chronic bronchitis, bronchiectasis, emphysema, bronchogenic carcinoma, cancer. So they are basically asking what does the smoke causes except one thing which is not smoking is directly related with. So for solving this question, we have to see a chart from Robbins. See this. Smoking actually it is causing a chronic injury and mainly it results in a small airway disease. So small airway disease which includes this emphysema and chronic bronchitis. So what happens in emphysema? Emphysema it is an alveolar wall destruction. So the alveolar walls are destructed and the lung is overinflated. And in chronic bronchitis, it is mainly the productive cough where there is an active airway inflammation. So apart from this, smoking also has been implicated in asthma where it causes a reversible obstruction. So it is nothing but all of us know that in bronchial asthma, bronchial hyperresponsiveness occurs, which can be triggered by this allergens, infections, etc. So we know that emphysema, out of all the chronic obstructive pulmonary airway disease, we know that emphysema, chronic bronchitis, asthma, and bronchiectasis constitutes this chronic obstructive pulmonary disease. And out of this, from this picture, we can know that it is emphysema and chronic bronchitis. And obviously, we know that it causes bronchogenic cancer. Okay, so the answer is bronchiectasis. So we'll see about all these diseases when we solve the subsequent MCQs. Let us see this question. The commonest type of emphysema is centri acina, obstructed emphysema, irregular emphysema, pan-acinar emphysema. Now see this question. A 45-year-old man with cirrhosis due to alpha-1 antitrypsin deficiency receives a liver transplant. He is at increased risk of developing which of the following types of emphysema? So basically this is also related to a type of emphysema, but what the history they have given is that it is a man who was presented with cirrhosis due to alpha-1 antitrypsin deficiency. So they are asking that indirectly they are asking us in alpha-1 antitrypsin deficiency, which type of emphysema is the commonest one? So the options they have given are centriacinar, paraseptal, pan-acinar, and compensatory. Then see this question. A 50-year-old male chronic smoker who smoked 20 cigarettes per day for the last 1 year died of severe respiratory distress. His lung biopsy showed the following. Identify the lesion. So they are asking us which type of emphysema causes this in common in the cigarette smoking. Centriacinar, pan-acinar, chronic bronchitis, or bronchiectasis. Which of the emphysema, following types of emphysema, predominantly occurs in basal areas of lungs? That is centriacinar, pan-acinar, irregular, distal acinar. So before solving all these MCQs, let us know what is emphysema is. So emphysema is nothing but it is defined as an abnormal permanent enlargement of the gas spaces. Yesterday we have seen the bronchial tree, no? So here in emphysema, you should know that it is the dilatation of the gas spaces that is distal to the terminal bronchiole. Okay, we have that respiratory bronchiole, terminal bronchiole, and alveolar duct and alveolar sac, no? So what happens in emphysema? Only the gas spaces that is distal to the terminal bronchioles are getting dilated. Okay, so it is, you have to remember the keyword that is distal to the terminal bronchiole. So it is accompanied by destruction of the walls, but without any obvious fibrosis. Okay, so there will be a destruction of the wall. So only there is a dilatation of the air spaces, but without any fibrosis. So the pathogenesis of emphysema, actually it is mainly now just we saw that it is smoking is an important risk factor. Apart from smoking, air pollutant or genetic predisposition, like given conditions like alpha-1 antitrypsin deficiency, all these risk factors increases the oxidative stress, increases the apoptosis and senescence, okay, the cellular aging, okay, they aggravate the cellular aging. So inflammatory cells and inflammatory mediators, all these things result in an alveolar wall destruction. And what happens in the smoking, an important mechanism, that is the protease antiprotease imbalance occurs. What happens normally that there is a balance between the protease and antiprotease mechanism. That is an elastase. Protease is nothing but it is an enzyme elastase, okay, which destructs the elastic fibers. And antiprotease is a mechanism which counteracts this elastase activity. So always there should be a balance between this protease and antiprotease activity. So what happens in smoking? Smoking increases the elastase activity. That is, smoking increases the protease activity. Okay. And congenital alpha-1 antitrypsin deficiency decreases the antiprotease activity. So the net result, imagine, so protease activity is increased and antiprotease activity is decreased. So the net result is the protease, that is the elastase activity, shoots up in the emphysema. So when the elastase activity is very high, it destructs the elastic fibers. Okay, so you know the lung is an recoiling organ. Okay, lung is full of these elastic fibers which has the capacity to recoil during inspiration and expiration. So what happens if the elastic fibers are destructed? So lung becomes a permanently dilated one. Okay, so the alveolar walls are destructed and the lung becomes a permanently dilated one. So let us see something about this alpha-1 antitrypsin. It is actually normally present in the serum, tissue fluids and macrophages. So normally in our body, this alpha-1 antitrypsin is a major inhibitor of proteases. Okay, so alpha-1 antitrypsin is an antiprotease in activity. So it inhibits the protease, okay, especially the elastase. So this alpha-1 antitrypsin is secreted by the neutrophils during the inflammation. Okay, so which chromosome codes for this alpha-1 antitrypsin? You should remember. It is encoded by the proteinase inhibitor, that is the PI locus on chromosome 14. Okay, this has been asked once in your exams. So alpha-1 antitrypsin has been coded from the chromosome 11 in the PI, chromosome 14 in the PI locus. So what happens in the emphysema? I told that it is distal to the terminal bronchiole. See, this will be dilated. Okay, so you can see here, this is the normal acinus, again respiratory bronchiole, alveolar duct and the alveolar sac. So you have different types of emphysema. You have different types of emphysema. That is, in the centriacinar emphysema, it is only the central part, that is the respiratory bronchioles alone is getting dilated. Respiratory bronchioles, if it is alone getting dilated, you call that as centriacinar emphysema, which is a very common in smokers. Okay, so remember the centriacinar emphysema commonly occurs in the upper lobe, that is in the apex. So centriacinar emphysema commonly occurs in the upper lobe, that is in the apex. Whereas see this panacinar, pan means pancreatitis, that means it affects the entire organ. So panacinar emphysema, it affects the entire acinus. Okay, that is the alveolar duct, alveolar sac, everything is getting dilated. Okay, irreversibly dilated. So such panacinar emphysema is usually seen in alpha-1 antitrypsin deficiency. Imagine it is an enzyme deficiency. Okay, so what happens in this enzyme deficiency? That is actually dilatation of the entire this acinus. Okay, so that is the alveolar duct and the alveolar sac, everything is getting dilated. And such type of panacinar emphysema is common at the lower zones at the base. Okay, so centriacinar, smokers, respiratory bronchiole, and panacinar, it is in the entire thing, alpha-1 antitrypsin deficiency in the lower zones at the base. Okay, so you can see from this image, can you guess what type of emphysema is this? It is a centriacinar emphysema. Okay, you can see some bronchioles are getting dilated here. You can see this dilated bronchioles, and this is the normal lung parenchyma. You can appreciate the dilated bronchioles here and the normal lung parenchyma. Compare that picture, previous picture with this picture. This picture is full of the dilated bronchioles. This picture shows full of dilated bronchioles. There is no intervening normal lung parenchyma itself. And this is panacinar emphysema. I told you panacinar means it affects the entire acinus. Okay, so you can get the uniform dilatation of the alveolar spaces in the pan-acinar emphysema. Such pan-acinar emphysema is common in the alpha-1 antitrypsin deficiency. Okay, so this is a histological picture. You can get it in the emphysema. You can see this is will be a normal air space, but see here, all the air spaces are irregularly dilated. Okay, these are all the alveolar spaces which are irregularly dilated. The alveolar septa are sometimes broken somewhere, and the prominent finding is the irregularly dilated air spaces. Yes. So now we'll solve this MCQ. Out of all the types of emphysema, the commonest type is the centriacinar emphysema. Centriacinar emphysema. And coming to this question, alpha-1 antitrypsin deficiency, the man presented with cirrhosis and this is a liver transplant. So the patients with alpha-1 antitrypsin deficiency or that increased risk of developing pan-acinar emphysema. Let us solve this question. That is a 50-year-old male. Yes, by this time you know that in smokers what type of emphysema? Yes, it is centriacinar emphysema. Okay, the patient died of severe respiratory distress. Okay, so centriacinar emphysema. And type of emphysema which predominantly occurs in the basal area of the lung, it is pan-acinar emphysema. Okay, so what happens in the irregular emphysema? In irregular emphysema, the dilatation is irregular. You cannot say that here it is the respiratory bronchiole is affected, here the alveolar duct is affected. You can't particularly delineate which area of the lung is affected. Okay, so it is a irregular dilatation. Distal acina, only the distal part of the acina is involved, whereas the respiratory terminal alveolar duct and all are normal, and only the distal acinas, if it is involved, you call that as distal acinar emphysema. Yes. So now try to solve this question which asks about chronic bronchitis. All are true about chronic bronchitis except increased Reed's index, submucosal gland hypertrophy, eosinophilic infiltration of the airways, bronchoria. So they have said 3 points are true about chronic bronchitis and one it's not true. What is that? So for knowing that, we'll see what is chronic bronchitis. Chronic bronchitis is actually a clinical definition. Please understand the difference. Emphysema is a pathological definition. Okay, so emphysema you define pathologically, and chronic bronchitis is actually a clinical definition. So the clinical definition is it is a persistent cough. The patient has persistent cough with sputum production for at least 3 months in at least 2 consecutive years. So the patient should have cough with sputum for at least 3 months in at least 2 consecutive years, in the absence of any other identifiable cause. In the absence of any other identifiable cause. And obviously, chronic bronchitis, smoking is a strong association. Okay, smoking is a strong association. In chronic bronchitis, what happens? See this. Usually in smokers, you will be getting this squamous metaplasia. Yes, metaplasia, you know, it is a conversion of one type of epithelium into another type. So what happens in the smokers? The pseudostratified, normally the pseudostratified ciliated columnar epithelium will be showing a metaplastic change like that of squamous. So it converts into squamous metaplasia. Yes. And what happens? The mucus glands, okay, the subepithelial mucus glands and all will be showing that hyperplasia. Okay, hyperplasia is increase in the number of the mucosal glands. Okay, so mucosal glands will be showing that hyperplasia. And also you will be getting the lot of inflammatory cells, macrophages, lymphocytes, etc. Let us see what is that Reed index. Okay, we have seen no Reed index. So what is the Reed index means? Reed index is nothing but it is a thickness of the mucus glands. It is actually a ratio. Reed index is nothing but it is a ratio. The numerator is the thickness of the mucus glands to that of the thickness between the basement membrane and the cartilage. Yes, I repeat it once again. Reed index is nothing but ratio of the thickness of the mucus glands, that is this area, that is the thickness of the mucus glands to that of the distance between the basement membrane of the epithelium to that of the cartilage. That is, basically it covers, like it shows how much the mucus glands occupy in the entire bronchus. Okay, how much the mucus glands occupy in the entire bronchus. This is normal rate index is usually around 0.4. Okay, around 0.4. But what happens in chronic bronchitis? What I told, in chronic bronchitis, you will be getting this you will be getting the increased mucus glands, that is mucus gland hyperplasia will be there. So what happens, you will be seeing that increased mucus glands thickness. So the numerator will be increasing. So the read index actually will be increased to more than 0.4. Okay, more than 0.4 in case of chronic bronchitis. Okay, so read index is more than 0.4 in chronic bronchitis. Okay. So let us see this, let us solve these questions. All are true about chronic bronchitis except increased read index. Yes, the normal read index is around 0.4. In chronic bronchitis, it is more than 0.4. And submucosal gland hypertrophy, yes, we saw that submucosal gland hypertrophy occurs. Bronchoria, yes, bronchoria means increased mucus gland production, which occurs in chronic bronchitis because the glands are undergoing hypertrophy. And it is eosinophilic infiltration of the airways. It is mainly in bronchial asthma you will be getting the eosinophilic infiltration of the airways and not in chronic bronchitis. Yes, eosinophilic infiltration of the airways is seen in bronchial asthma. Now let us see this question. Kirschmann spirals are found in bronchitis, asthma, bronchiectasis, lung abscess. So they are asking where you will see the Kirschmann spirals. So solve this question. Typical bodies in bronchial mucosa from sputum of the patient is seen in bronchial asthma, emphysema, chronic bronchitis, and bronchiectasis. So now before answering this question, let us see what's happening in bronchial asthma. So in a bronchial asthma, whenever the person is exposed to a pollen, it is an allergen. Okay, whenever the patient is exposed to a pollen or an allergen, usually it is processed by the T cells. Okay, the T helper 2 cells. Okay, this process and activates the B cells, and T helper 2 cells process the antigen and gives the antigen, process the antigen, and via these B cells. Okay, B cells, and by activate the B cells via the interleukin 4. So it is from these B cells only all these immunoglobulins will be arising. So these B cells will be producing this IgE antibodies, and this IgE, okay, remember your type 1 hypersensitivity. You know that in type 1 hypersensitivity, it is the mainly IgE antibodies, antibody mediated, and it is mainly the IgE. So the IgE antibodies will be attached to the mast cells and it will be liberating the chemical mediators. Further, eosinophils are also recruited in the site of action by the releasing this interleukin 5. So more and more eosinophils will be recruited into the site. Okay. So eotaxin also is a chemical mediator which recruits more number of the eosinophils to the site of injury. Okay. This is what happens in the asthma. And after this, what happens? There will be like a more of inflammatory response which is happening in the bronchial tree because the pollen or any allergen has activated all the inflammatory pathways in the bronchial mucosa. So it is full of the inflammatory cells, and especially now coming to the role of eosinophils. Eosinophil releases all its chemical mediators resulting in the vascular permeability. So what happens? The chemical mediators increases the vascular permeability. So once the vascular permeability is increased, you get more of edema. Okay, that is the fluid accumulation. Okay, and eosinophils also stimulate, releases its own chemical mediators like major basic protein and eosinophilic cationic protein. So these proteins will be further activating the mucous membrane, that cells, and resulting in the increased mucus production. Okay, so these are all the things happening in the bronchial asthma. Okay, so what happens in the normal airway? It is mainly the mucus glands will be there, and in asthma, the mucus gland thickness will be more, and you will be getting the more amount of mucus. And inflammatory cells that is rich in neutrophils and eosinophils will be there. And glandular hypertrophy, also hypertrophy and hyperplasia both occurs in asthma. Okay, what are the two types of asthma? You know, there are two types of asthma: extrinsic asthma and intrinsic asthma. There are two types of asthma: extrinsic asthma, intrinsic asthma, that is atopic asthma, okay, and non-atopic asthma, okay. So extrinsic asthma is basically an allergy mediator, okay, an allergy mediator, that is the antibody mediator, especially which occurs in the children and in with a family history of allergy. In the background of that, if a child is developing an asthma, it is mainly the extrinsic asthma. So you can remember in this extrinsic asthma, it is mainly the antibodies are playing a role, especially IgE, yes, immunoglobulin E. So if we estimate the immunoglobulin E, it will be elevated in asthma, extrinsic asthma. Okay, and what happens in the intrinsic asthma? Intrinsic asthma, there is no such genetic predisposition, and even actually there is not a family history. But the patient is sensitive to the things like aspirin, exercise-induced asthma, aspirin-induced asthma. Such kind of asthma are called as intrinsic asthma. Yes? And genetics of asthma has been a favorite questions of your examiners. And chromosome 5q polymorphism, that is the gene encoding in the interleukin 3, 4, 5, 9, interleukin 13 gene. And you have to remember this gene, that is the polymorphism in the Adams 33 gene. All this has been implicated in the genetics of asthma. Recent studies have found out serum estimation of the serum levels of a protein called as YKL40. Yes, I repeat, estimation of the serum levels of YKL40 correlates with the disease severity in asthma. Correlates with the disease severity in asthma. This is what you can see in the sputum of the asthma patients. These are nothing but, these are called as Kirschmann spirals. These are called as Kirschmann spirals. As you can see, this spirally bound protein. Actually, this is nothing but when the patient of bronchial asthma coughs out the sputum. When he coughs out the sputum, what happens? The sputum is expelled along with the bronchial epithelial cells. Okay, the mucus, there will be mucus plugging in the bronchus, no? So when the patient tries to cough up the sputum comes out with along with the shed bronchial epithelial cells in the form of a spiraling, and these spirals are called as Kirschmann spirals. Kirschmann spirals. That is the sputum with bronchial epithelial cells. This is the Crayola bodies, that is the famous Crayola bodies, that is nothing but also a sloughed bronchial epithelial cell. This is also a sloughed bronchial epithelial cells. You can see this is a three-dimensional cluster, and you can see these bronchial epithelial cells will be having the cilia also. Can you appreciate this? Hair-like projections from the epithelium. Okay, these ciliary projections can be seen in the bronchial epithelial cells, and when they are sloughed out, when you are seeing it as a lavage, when you do a bronchoalveolar lavage and you get such kind of cellular clusters, you call it as a Crayola bodies. Crayola bodies. So now see, Hirschman spirals are found in bronchitis, asthma, bronchiectasis, lung abscess. You know that it is asthma. Typical bodies, what they mean is Crayola bodies. Yes, Crayola bodies in bronchial mucosa from sputum of the patient is seen in bronchial asthma. Yes. So now let us see this question. The complication of bronchiectasis are all except septicemia, carcinoma bronchus, lung abscess, cerebral abscess. So for solving this MCQ, we'll see what is bronchiectasis. Bronchiectasis is nothing but it is a destruction of the smooth muscle and elastic tissue. Okay, so basically what happens is there is a destruction of the smooth muscles and elastic tissue occurs, and it is mainly by the necrotizing infection which lead to permanent dilatation of the bronchi and bronchioles. Okay, the key word you should note down here is there occurs a permanent dilatation of the bronchi as well as the bronchioles. That is the bronchi, that is a larger air space. The larger air space is also getting dilated in the bronchiectasis. Yes. So Bronchiectasis, actually you can grossly see this, what is called as an, can you see this lung? Okay, you can see these are the dilated bronchi and the bronchioles, and this type of lung with the dilated bronchi is called as honeycomb lung. Okay, this is called as honeycomb lung. So honeycomb lung is seen in bronchiectasis because of the dilatation of the bronchi. Okay, you have two types of bronchiectasis, that is the congenital bronchiectasis and the acquired bronchiectasis. Yes, acquired bronchiectasis usually when you get an obstruction in the bronchi. Where else you can get an obstruction in the bronchi? Commonly, you can get an obstruction in the bronchi mainly due to the any carcinoma or any foreign body obstructing the bronchus. So it can be a carcinoma or it can be a foreign body which can obstruct the bronchus, and that can result in the stagnation of the secretion. That is, the secretions are not properly drained out. Okay, so you can get the obstruction resulting in the increased secretion, and this will be resulting in an inflammation. So inflammation, infection, secretion, so this becomes a vicious cycle. Okay, so the airway are getting distracted. Okay, these occurs in the acquired bronchiectasis. Tell me an example of congenital bronchiectasis, and you'll be knowing that familiar terminology, that is a Cartagena syndrome. Yes, Cartagena syndrome is a condition in which you get congenital bronchiectasis. Actually, what happens in Cartagena syndrome? Cartagena syndrome, actually, it is a mutation in the dynein protein. The mutation in the dynein protein, it is actually a protein in the cilia of the bronchus. Cilia of the bronchus are effective in draining the secretions. So what happens if the cilia itself is getting mutated? Okay, it's not functioning properly, and you get bronchiectasis. And because of this, dynein proteins are also expressed in the sperms. Sperm motility is getting affected. Yes, for sperm motility, this dynein protein is needed. But because of the absence of this dynein protein, sperm becomes immotile and patients can present with infertility. Yes, infertility. So sinusitis, bronchiectasis, male infertility, and situs inversus. So all these constitutes the Cartagena syndrome, which in case is the cause of congenital bronchiectasis. Okay, so please remember the congenital bronchiectasis, Cartagena syndrome, and gross, you can get honeycomb lung. Okay, so now you can think of what happens in the complication of bronchiectasis. Yes, I told in the bronchiectasis always there occurs a stasis of the secretion. So when the secretion occurs stasis, what happens? So it becomes an infected. So infected, so septicemia, lung abscess, yes, abscess cavity, abscess can formation can the, and cerebral abscess, but usually bronchiectasis will not lead on to carcinoma bronchus. Yes, carcinoma bronchiectasis may lead on to septicemia, that is because of the infection and inflammation, lung abscess, okay, lung abscess and the cerebral abscess, even the metastatic abscess also can occur, but carcinoma will not usually occur in bronchiectasis. Okay, so other complications of the bronchiectasis may also include amyloid. Yes, amyloid deposition can occur in bronchiectasis. Which type of amyloid? You have two types of amyloid, AL amyloid and AA amyloid. AL stands for amyloid light chain and AA stands for amyloid associated. And in bronchiectasis, you will be having AA type of amyloid. Yes, these are all the complications of bronchiectasis. Now solve this question. All are true about silicosis except eggshell calcification, nodular fibrosis, bloody pleural effusion. Quartz is the main form implicated in the pathogenesis. Quartz is the main form implicated in the pathogenesis. Solve this question. The cut surface of lungs in silicosis shows pleural thickening, hard collagenous scars, nodules, all of the above. True about silicosis is starts in the upper zone of the lungs. A crystalline form of silica is more fibrogenic, associated with the pleural thickening and all of the above. Let's see what is silicosis. Silicosis is also called as grinder's disease. Yes, It is actually the most prevalent occupational disease in the world. Yes, silicosis is the most prevalent occupational disease, that is a pneumoconiosis in the world. Okay, people who are working in the sandblasting industry, marble industry, granite industry, pencil factories, okay, all these glass binders. So all these things or workers are predisposed to the hazard of silicosis. So what happens? The disease progresses even after the exposure ends. That is, a person who is working in the silica industry will inhale all these silica particles, which are these particles are usually less than 1 to 5 microns. So these particles are not filtered by the normal cilia. The normal cilia is not able to filter the small particles. So what happens? These small particles escape the filter mechanisms and directly reach the base of the lung. So after reaching the base of the lung, they activate the macrophages, and in turn the macrophages can't keep quiet, no? They release all the fibrogenic factors. So these fibrogenic factors will be causing fibrosis in the silicosis. So what is the important point? You should know this. The disease progresses even after the exposure ends. Okay, so even if you remove the patient from the silica industry also, once that fibrosis has started, the disease progresses in a continuous manner. Okay, another interesting point to note is it has increased susceptibility to tuberculosis. Patients with silicosis are more susceptible to tuberculosis because of there is decreased cell-mediated immunity. So out of all the forms of silicosis, it is a crystalline form which is more fibrogenic. Crystalline form is more fibrogenic. So this is a gross appearance of a silico lung, and you can see mainly it is affected in the upper lobe. Okay, see there is a upper lobe, and you can see the silica nodule. Okay, this is the silica nodule, which is nothing but a fibrotic one. I told no, the silica when it goes to the base of the lung, it activates the macrophages. So these macrophages will release that fibrogenic factors, and this results in the fibrotic nodules, especially in the upper lobe of the lung, especially in the upper lobe of the lung. And you can demonstrate this like you do a Mason trichome stain. It highlights this fibrosis. Yes? And this is a histology which you can show here, which you can see here, fibrotic nodule, and you can see these silica crystals. Okay, these empty white spaces or the silica crystals. Okay, and when you see a polarized microscope, when you see in a polarized microscope, you can see that silica crystals, you can easily see this will be highlighted by this in this polarizing microscope. And this Apollo fibrosis usually in X-ray. X-ray, this will be mimicking as a eggshell calcification. Okay, so eggshell calcification in X-ray in the lung is suggestive of silicosis. Yes. So now see what happens. All are true about silicosis except, yes, you know, eggshell calcification, nodular pleural effusion, and out of these two things, yes, what happened? Bindu Surya has raised hand. Anything you can, any doubt or anything you can put it in the chat box. Quartz is the main form implicated in the pathogenesis. So the answer for this question is the bloody pleural effusion. Any doubt you can put it in the chat box. We are ready to help you. So usually the blood pleural, usually bloody pleural effusion will not be there. Okay, so usually malignancy will have this pleural effusion, which is mostly of blood stained. Okay, so quartz is also quartz crystalline form. All these are all implicated in the pathogenesis of silica. Yes. The cut surface of the lungs in silico shows, yes, pleural thickening can be there, hard collagenous scars can be there, and nodules can be there. So the answer is all of the above. Yes, true about silicosis is it starts in the upper zone of the lung. Yes, we saw that. A crystalline form of silica is more fibrogenic. Yes, and associated with pleural thickening. So the answer here is all of the above. Let us solve this question. Which of the types of asbestos is least associated with mesothelioma? So they are asking which type of asbestosis is least associated, whether it is a chrysolite, crocidolite, amosite, tremolite, and they have given actually the options is whether it is A, BC, AC or B. Cancers caused by asbestosis, all except adenocarcinoma of the lung, mesothelioma, gastric carcinoma, and pancreatic carcinoma. Let us solve this question. A 70-year-old man has worked in the asbestos industry for a long time. On routine examination, a mass was detected in the apex of the right upper lobe. Which of the following is the characteristic electron microscopic appearance of the mass? So you should know that the patient is working, the man is working in the work for a long time in the asbestos industry. So he is now presenting with a mass. So you should know that what is the mass in the lung, which is because of the asbestos. And if you know that, you can answer this thing microscopically, electron microscopically, what you can see. That is whether you can see a neurosecretory granules in the cytoplasm, large tubular cells with long villi on their surface, melanosomes, cross striations, and desmosomes. For solving all these questions, you have to know about asbestosis. Yes, asbestosis is the most actually important hazardous agent who is the people for the people who is working in the asbestos industry. And in asbestosis, please remember the most common manifestation is the pleural plaque. The patient presents with a pleural plaque that is in the thickening of the pleura. That is thickening of the pleura. And the most common site of this pleural plaque will be the anterior and the posterolateral aspects of the parietal pleura. Okay, you can see this. This is in the pleura. You can see in the pleura, you can see this nodular thickening like this thing. Okay, such kind of pleural thickening is common in the asbestos. Okay, asbestosis. And lung parenchyma, this happens in the pleura, but what happens in the lung parenchyma? There is a diffuse interstitial fibrosis. That means diffuse, entire, interstitial, intervening connective tissue, fibrosis. Okay, that is a scar tissue happening in the lung, especially in the lower lobe. Okay, so asbestosis, you can get pleural plaque and you can get diffuse interstitial fibrosis. And coming to the malignancy, you get a wide variety of carcinomas associated with asbestosis. And remember, it is a bronchogenic carcinoma, which is the most common cancer associated with asbestosis. Yes, it is a bronchogenic carcinoma, which is most commonly associated with asbestosis. Out of the bronchogenic carcinoma, you have adenocarcinoma is more common than the squamous cell carcinoma. Adenocarcinoma more common than the squamous cell carcinoma. Coming to mesothelioma, you people may have doubt. You would have heard that asbestos mesothelioma. Please remember, mesothelioma is the most specific cancer. Bronchogenic cancer is the most common cancer. Okay, you have to understand the subtle difference between these two questions. Okay, if they ask you most common cancer with asbestos is right bronchogenic cancer. If they ask the most specific cancer for the asbestosis, you have to write mesothelioma. Okay, so the other cancers which can be associated with asbestosis are carcinoma larynx, carcinoma stomach, carcinoma colon, and renal cell carcinoma. Yes, and you can see this a peculiar body. Okay, in the sputum of the patients. In the sputum of the patients with the asbestosis, you can get a peculiar body called as ferruginous body. Ferruginous body or asbestos body. Ferruginous, Fe now, that is for iron. Yes, this is nothing but the asbestos fibers which has been coated with the iron proteins. Okay, the iron glycoproteins coated with iron cover this asbestos fibers, and this is expelled in the sputum of the patients with asbestosis. And these bodies are very characteristically seen in asbestosis. So they are called as ferruginous body or asbestosis body. So coming to this question, which of these types is least associated with mesothelioma? It is A and C. That is chrysolite and amosite are least associated, whereas chlorsidolite and tremolite are the most type of asbestos which is associated most commonly with the mesothelioma. And now you can be able to solve this question. Cancers caused by asbestosis is all except, that is the adenocarcinoma of the lung, mesothelioma, gastric cancer. And the option is pancreatic cancer. Yes, we saw that it causes adenocarcinoma, it causes mesothelioma, it causes gastric carcinoma, whereas it is not implicated in the carcinoma of the pancreas. Coming to this question, yes, now by this time you know that what is the cancer we are talking about. Okay, it is the asbestos industry for a long time and mass was detected in the right upper lobe. Okay, so they are asking about the electron microscopy. Neurosecretory granules. Where you will see neurosecretory granules? Usually such granules you will be seeing in the small cell carcinoma of the lung. Okay. And here in the mesothelioma, the carcinoma, the patient is worked for a long time in asbestos. So the most specific cancer for this asbestos workers is the mesothelioma. And electron microscopically, the mesothelial cells, are the large tubular cells which have a long villi on their surface, okay, which will have the long villi on their surface. So this is very characteristic of the mesothelial cells. So in mesothelioma, you'll be getting the malignant proliferation of the mesothelial cells, okay. So such things you can see in an electron microscopy. Melanosomes usually you'll be getting in malignant melanoma, which you will not see here, and you will not see the other option also. So the answer here is large tubular cells with long villi on their surface. Now let's solve this question. A 56-year-old male presented with severe respiratory distress, high-grade fever, and streaks of blood in sputum, and he dies 7 days after hospitalization in ICU. Lung autopsy has been shown and identify the pathology. Is it lobar pneumonia, bronchopneumonia, tuberculosis, or bronchogenic cancer? And the other question is, which are all of used to differentiate atypical pneumonia from typical pneumonia? Whether it is the amount of sputum, or presence of consolidation, or levels of WBC, or all of the above. Coming to this question, which of the following is the gray hepatization of the pneumonia? That is, WBCs fill the alveoli, RBCs fill the alveoli, organisms fill the alveoli, and accumulation of fibrin. So for solving these questions, we have to know about a little bit about the pneumonia. There are two types of pneumonia. One is the lobar pneumonia. Lobar pneumonia is nothing but the continuous involvement of the entire lobe. Okay, see this. The entire lobe is going for the consolidation. So it is a continuous involvement of a lobe. Whereas in bronchopneumonia, the involvement is patchy. Okay, it is only around the bronchioles. Okay, only around the bronchioles you will be having that inflammation that is called as bronchopneumonia. So please remember, in lobar pneumonia it is a continuous involvement, and in bronchopneumonia it is a patchy involvement. Okay, yes, this is how the picture from Robbins looks like. Okay, it shows you the features of bronchopneumonia and lobar pneumonia. You can see the lobar pneumonia, there is a continuous involvement. The entire lobe is affected. Whereas in bronchopneumonia, you can see here this patchy involvement. Okay, so in between you can see a normal lung parenchyma, and here you can see the involvement of the consolidation, and especially around the bronchioles. And your traditional classification of the stages of the pneumonia, that is the stage of congestion, stage of red hepatization, stage of congestion, stage of red hepatization, stage of gray hepatization, and stage of resolution. So what happens in the stage of congestion? The lung parenchyma is getting congested with more of all the blood vessels will be very much turgid in the stage of congestion, and we will be getting a pink frothy fluid in the alveolar space. But the next stage, that is a stage of red hepatization. What do you mean by hepatization? That means change in the spongy architecture of the lung. You know the lung is of a spongy architecture because of the aerated spaces. But what happens in pneumonia, lobar pneumonia? The aerated spaces are filled with the inflammatory cells. Okay, they are filled with the neutrophils. So there is no space for the aeration itself. There is no air in the lung itself. So the unaerated lung, which has now become a consistency like that of a liver. Okay, the change in the consistency of a lung to that of a liver-like architecture, liver-like consistency is called as hepatization. And since it follows the stage of congestion, the next stage is red hepatization. Yes. And what happens in gray hepatization? Slowly the congestion wanes off and you get this more of macrophages digesting all these infectious particles. Okay, and the last stage is the stage of resolution when the entire thing is solved and you can get is the, what is this thing? You can see is the fibrotic lung. Okay, so you can get a fibrosis and sometimes the air spaces are getting cleared. Okay, and also you should know about the difference between the typical pneumonia and atypical pneumonia. So typical pneumonia is nothing but it is caused by the mainly the bacterial agents. That is the Staphylococcus pneumonia, and Klebsiella and Pseudomonas. Whereas atypical pneumonia is caused by Mycoplasma, viral infections like influenza and respiratory syncytial virus, chlamydia, Coxiella, and pneumocystis. So mainly the bacterial infection causes a typical pneumonia and viral and mycoplasmal organisms cause this atypical pneumonia. What is the most important features which can differentiate the typical and atypical pneumonia? See this. Actually, in a typical pneumonia, you'll be getting a productive cough. Okay, you get a productive cough. Whereas in atypical pneumonia, you get a dry cough. Okay, you remember viral pneumonia causes a dry cough. Even your COVID causes your dry cough. Okay, dry cough is a symptom of the viral pneumonia. You can remember COVID causes this dry cough. Okay, so it is mainly the pneumonia caused by the coronavirus, that is the COVID-19 is a atypical pneumonia. Yes. Okay, so in typical pneumonia, the infiltrate is mainly the neutrophils, whereas in atypical, you get lymphocytes. In typical, mainly the exudate. Okay, that is a collection, that is the frothy fluid, is mainly in the alveoli, that is a consolidation is in the alveoli. Whereas in atypical, there is no such exudate. So the air spaces are there, so there is no consolidation. Okay, so this is the main important difference between a typical pneumonia and atypical pneumonia. Now let us see this question. A 56-year-old male who presented with a severe respiratory distress and high-grade fever. Yes, when a person is presenting with a respiratory distress and a high-grade fever with a sputum, okay, and you have to think of lobar pneumonia where there is a continuous involvement. And which are all of used to differentiate atypical pneumonia from typical pneumonia? It is all of the above. Yes, we have seen that. Okay, amount of sputum, presence of consolidation or not, and the levels of WBC. Okay, so it is neutrophils in case of typical pneumonia and lymphocytes in case of atypical pneumonia. Which of the following is gray hepatization of pneumonia? Yes, it is mainly that actually now the stages of the RBC, neutrophils, and the macrophages have weaned out, and here mainly it is the accumulation of the fibrin. Coming to the carcinoma of the lung, we solved some MCQs with the carcinoma of the lung. That is the most common lung cancer associated with ectopic ACTH. Okay, ectopic hormone production, adrenocorticotropic hormone. That is, they are asking whether it is small cell cancer, carcinoid, squamous cell cancer, adenocarcinoma. Which cancer lung is diagnosed by? Is a diagnosis by exclusion. That is, you can't diagnose this directly. It is a diagnosis by ruling out the other cancers, which is such cancer. Whether it is adenocarcinoma or small cell carcinoma, large cell carcinoma or squamous cell carcinoma. All are true about adenocarcinoma of the lung, except more common in female. Smoking is not associated with this adenocarcinoma. Central cavitations, peripheral involvement. Which type of bronchogenic carcinoma is strongly associated with cigarette smoking? Obviously, we know that cigarette smoking causes bronchogenic carcinoma, but which type is strongly associated with cigarette smoking? Whether is it squamous cell, is it adeno, is it small cell, is it large cell? Solve this MCQ. A 65-year-old male presented with chronic cough and hemoptysis. Investigations revealed a grayish-white tumor located at the central bronchus causing distal bronchiectasis. Yes, you know, no, I told you, no, when there is a tumor obstructing the bronchus, it causes the bronchiectasis and recurrent pneumonia. The biopsy of the tumor is more likely to show spindle cells with the abundant stromal matrix, all the three germ cell layers, abundant osteoid matrix formation, small round cells with hyperchromatic nuclei and with nuclear molding. So solving all these MCQs, we should know about the carcinoma lung. Okay. So which is the most common cancer, lung cancer worldwide? Now the answer is adenocarcinoma. Okay. Previously it was squamous cell, but now the worldwide, the most common type of lung cancer is adenocarcinoma. And even the adenocarcinoma is the most common lung cancer in non-smokers, the most common lung cancer in the women, the most common lung cancer in young age. All these are all adenocarcinoma. And remember, the lung carcinoma with good prognosis is adenocarcinoma, and lung carcinoma with the worst prognosis is the small cell carcinoma. Yes, and even in the small cell carcinoma is a carcinoma which is prone for this paraneoplastic syndrome. You know what is a paraneoplastic syndrome? That is, these tumors will elevate the hormones or hormones like peptides, and this will be causing the symptoms related to that. Okay, that these tumors can elaborate ACTH. So this ACTH may cause Cushing syndrome. So these tumors can elaborate the parathormone-like substance, and this may cause hypercalcemia. Okay, so the tumors, it is not due to the direct effect of the tumor, but because of the hormones elaborated by the tumor, you will get this paraneoplastic syndrome, and your small cell carcinoma is prone to develop such paraneoplastic syndrome. And it is a carcinoma with worst prognosis. And remember, out of all the cancers, it is a small cell cancer as mainly the implicated in the smoking, as a strong association with the smoking. Okay, so if a person is having a small cell carcinoma, 99.9% he is a smoker. Yes. Coming to the histology of this carcinomas, you can see this from these pictures. This is, you can see a glandular pattern. Okay, see this glandular pattern, and the tumor which is arranged in the glandular pattern is the adenocarcinoma. And this is a marker called as thyroid transcription factor, which is positive in these tumors. Okay, so let us see this picture. What you are seeing in this picture? Here you can see the nest of squamous cells. Okay, you can see these keratin peels. These are called as the keratin peels. Such keratin peels and the nest of squamous cells, if you see in lung tumor, you diagnose that as a squamous cell carcinoma. Okay, this is the nest of squamous cells with this keratin peels. That is a whorl-like appearance. And you can see in this picture, these are the small cells. Okay, and small cells, you can see these granules. Okay, the chromatin is showing these granules, and these granules are called as salt and pepper chromatin. Yes, that is also one more MCQ. Salt and pepper chromatin is seen in a small cell cancer, small cell carcinoma. So this salt and pepper chromatin, it is mainly because of the neurosecretory granules which are present in these small cells. Okay. And what is depicted in this picture is, you can see this is around a blood vessel, and there is something like a smudging of the nuclear chromatin. Smudging. Okay, you can see the nuclear chromatin, that is the nuclear material, is showing some type of smudging appearance. Okay, so this type of smudging appearance around a blood vessel is called as Azo Body Effect. PARDI, Azo Body Effect. So Azo Body Effect is commonly seen in small cell cancer. Okay, salt and pepper chromatin, small cell cancer. Okay, necrosis, very aggressive tumor, small cell cancer, strong association with smoking, small cell cancer, and carcinoma with ectopic hormone production, small cell cancer. Yes. And we have read this adenocarcinoma, squamous cell and small cell, and the diagnosis of exclusion is the large cell carcinoma. As the name itself suggests, see this. And you can see all these are all the large cells. Okay, these are all the large cells with a nuclear chromatin. Okay, with a prominent nucleoli. Okay, so this is the diagnosis by exclusion, and it is the large cell cancer. So now I think you will solve all these MCQs. The most common lung cancer associated with ectopic ACTH, it is? Yes? Okay. Sorry, the answer is small cell cancer. Which cancer the lung is diagnosed by exclusion? It is large cell carcinoma. All are true about adenocarcinoma of the lung except more common in females. Smoking is not associated with adenocarcinoma. Yes, can be not associated with adenocarcinoma. Peripheral involvement, it involves the periphery and central cavitations. Usually you will not see in adenocarcinoma. Okay, central cavity, okay, that is a cavity formation. If you see in a lung cancer, usually you are dealing with a case of squamous cell carcinoma. Usually you are dealing with a case of squamous cell carcinoma. Which type of bronchogenic carcinoma is strongly associated with cigarette smoking? And it is small cell carcinoma. Okay, a 65-year-old male with a chronic cough, hemoptysis, grayish-white tumor, central bronchus, distal bronchitis is recurrent pneumonia. The biopsy of the tumor cells is showing that nuclear small round cells. Okay, so these spindle cells and all you will be getting in sarcoma. All three germ cell layers you will be seeing it in your teratoma, which is not common as in a lung tumor. And osteoid matrix formation you will see in osteosarcoma, which is not seen in lung tumor. And what they are dealing with is a small cell carcinoma. So you get a small round cells with hyperchromatic nuclei with nuclear molding. Okay. So with this, we are finishing the MCQs. And now we'll try to solve the few worksheets. So let us see these worksheets. First, I'll be putting the questions. Onion skin thickening of the arteriolar walls is seen in. Most common artery involved in giant cell arteritis is classic tetrad of Henach-Colin purpura. Syphilitic aneurysm most commonly affects which part of aorta? Vessels paired in polyarteritis nodosa. Earliest light microscopy change in myocardial infarction. Characteristic pathologic finding in rheumatic fever. Most common valve involved in infective endocarditis in IV drug users. Small, flat, verrucous, sterile vegetations seen on both surfaces of the valve is seen in most common primary tumor of the heart. Let us see the answers. Onion skin thickening of the arteriolar walls is seen in hyperplastic arteriosclerosis. Most common artery involved in giant cell arteritis is temporal artery. And the classic tetrad of Henach-Colin purpura is palpable purpura, arthritis, glomerulonephritis, abdominal pain. These four features, if you remember my class, I told this is the tetrad. Okay, that is a palpable purpura, arthritis, glomerulonephritis, and abdominal pain. Syphilitic aneurysm mostly affects which part of the aorta? It is proximal ascending aorta. And vessels paired in polyarteritis nodosa, I repeated many times, it is pulmonary vessels. Earliest light microscopy change in myocardial infarction, it is a waviness of the fibers. Characteristic pathologic finding in rheumatic fever, all of you know that it is Ascough bodies. Most common valve involved in infective endocarditis and IV drug users. Okay, that is the right side of the heart. That is a tricuspid valve. And small, flat, verrucous, sterile vegetation seen on both the surfaces of the valve is seen in Liebman-Sachs endocarditis. I told you LSE, that is a seen in SLE. Yes. Most common primary tumor of the heart is myxoma. The types of vasculitis can be asked. Chokestor syndrome, giant cell arteritis, granulomatosis with polyangiitis, that is a vaginous granulomatosis, Takayasu arteritis, polyarteritis nodosa. Now let us see which type of vasculitis is each this thing. So Chokestor syndrome is small vessel vasculitis. Giant cell arteritis is large vessel vasculitis. Granulomatosis with polyangiitis, that is a vaginous granulomatosis, is small vessel vasculitis. Takayasu arteritis is a large vessel vasculitis. Polyarteritis nodosa, that is a PAN, is a medium vessel vasculitis. Let us solve some another one worksheet. Characteristic histopathological finding in shock lung. Hyaline membrane is made up of emphysema associated with alpha-1 antitrypsin deficiency, components of Cartagena Syndrome, ferruginous bodies are seen in, most common cause of community-acquired pneumonia, progressive massive fibrosis in association with rheumatoid arthritis is called, bilateral hilar lymphadenopathy with non-casheating granuloma is seen in, most common lung cancer in non-smokers and females, most aggressive lung cancer with worst prognosis. Let us solve the solutions. Characteristic histopathological finding in shock lung is the diffuse alveolar damage. The alveolar fully getting damaged. Hyaline membrane is made up of fibrin and necrotic cells. Emphysema associated with alpha-1 antitrypsin deficiency, it is the pan-acinar emphysema. The components of the Cartagena syndrome is the bronchiectasis, sinusitis, situs inversus, and male infertility. Ferruginous bodies are seen in asbestosis. Most common cause of community-acquired pneumonia is streptococcal pneumoniae. Progressive massive fibrosis in association with rheumatoid arthritis is called Kaplan Syndrome. Very important thing. Rheumatoid arthritis plus massive fibrosis. In colorectal pneumoconiosis, it is Kaplan Syndrome. Bilateral hilar lymphadenopathy with non-casheating granuloma is seen in sarcoidosis. Most common lung cancer in non-smokers and females is adenocarcinoma, and most aggressive lung cancer with worst prognosis is small cell carcinoma. Okay, I hope you enjoyed the class. So thank you very much for your patient listening. Any doubt? So thank you very much.
Yeah. Thank you, Dr.